Okay, so we actually stopped at Tums versus Maalox, being that Tums should be used in situations where people have problems, kidney problems, or sometimes the elderly because they're vulnerable to kidney problems. So Gaviscon and Maalox have magnesium in them, and magnesium can build up and be dangerous, actually, in people who have kidney problems. So Tums and Gaviscon and Maalox are all used kind of in people who would have infrequent, so not very frequent, attacks of reflux or GERD. Things that we might use to reduce the acid to begin with would be proton pump inhibitors and H2 blockers. For our purposes, proton pump inhibitors and H2 blockers are the preventative acid reducers. We don't need to get into the minute biochemistry of them all. They're slightly different. They have slightly different risks, benefits, but ultimately they're very similar. Proton pump inhibitors, you definitely don't want to take these with antacids because they inhibit them. Take on an empty stomach, take them prior to eating, and do not chew them. People are used to chewing their Tums. They need to be told this when they start a proton pump inhibitor. It would be disgusting anyway. So H2 blockers, very similar. They interact with many medicines. So antacids will also inactivate H2 blockers, just like proton pump inhibitors, so don't take them together. Cimetidine and ranitidine are examples of H2 blockers. Don't take more than one version. So if you're on H2 blockers, don't take proton pump inhibitors. If you're on one H2 blocker, don't take another. And again, these are really actually the preventative types that you could take. Something that can be given also is something called Carafate. Carafate works differently. It's really a stomach coater. It's given on an empty stomach before meals, not with antacids. Works by adhering to ulcer sites, actually, and protecting them from the acids, the enzymes, and the bile salts. So it's something that's used kind of in a more harsh situation than even the H2 blockers and the proton pump inhibitors. So vomiting and antiemetics, we tend to look at suppressing the chemoreceptors in the brain. For vomiting in pregnancy, Unisom and B vitamins, so Unisom is doxylamine, and B vitamins are really the key in that. We used to use Zofran a lot, but it did move into a more dangerous category. It's now, I believe, a category C, and we are looking into some more of possible teratogenic effects. Zofran and Ativan are both antiemetics. Zofran comes in a 4 milligram dissolvable tablet, and Ativan comes in tablets and IV and actually IM too. And Ativan works best with, it's the best drug to use with cancer patients who need antiemetics. It just works the best. Phenergan is another type of antiemetic if other antiemetics are not working. Phenothiazine is one of them. So phenothiazine, Phenergan is a phenothiazine. It's a neuroleptic, so it can cause those extrapyramidal symptoms, EPS, like dystonia and Parkinsonian symptoms. We want to try to give this centrally if possible. This is really harsh on the veins. Another antiemetic that can be used is something called Reglan. Metoclopramide provides gastric emptying, which is nice when that is the problem and that is what's causing the nausea. It also suppresses nausea centers in the brain. We want to go back to Zofran. We want to make sure that you know that it is currently under surveillance by the FDA for teratogenic effects. Report any funny or skipped heartbeats. Report any confusion, as serotonin syndrome is a risk with the Zofran. Emetics. Here we've got unicorn barf. We don't use emetics very often anymore. Emetics were things like the syrup of ipecac that made people vomit. Again, we don't use these anymore. They just increase the risk of aspiration and aspirating things that are really, really harsh to the lungs. We move on to diarrhea, which is a fun thing to move towards. There are different causes. Sometimes it's just the natural flora is not properly balanced in our body. But antidiarrheals that we can use are things like Lomotil. Lomotil has atropine in it. And so you're going to get all of those things that atropine can cause. Here's the deal is we don't want to take atropine with C. diff. So atropine is given to decrease all of the movement in the GI tract, and that's what Lomotil does. It decreases that movement, decreases that diarrhea in that manner. Don't take with C. diff because we want to actually get rid of C. diff. C. diff has a toxin in it that we need to get out of our body. We also don't want to use this with patients with glaucoma. Constipation. So this right here is someone who, this poor patient is full of poop. And so that's what this x-ray is showing here. Really, when we're talking about constipation, we want to talk about fluids, getting up and moving, and dietary fiber. Then we want to talk about the different things we can provide pharmacologically. Miralax, Metamucil, Colace, Senna, Meg citrate. In nursing homes, we're very, very focused on if somebody doesn't have poop for 3 days, sometimes we'll go with a suppository or an enema. We really don't want impactions or obstructions in this population. They're at high risk for that, so we will do that. But we are definitely working on fluids and movements and proper diet with elderly people too. So when we stop, we talk about milk of Meg. A lot of elderly people and family members can get very reliant on milk of magnesia. But we do want to teach that this can too often lead to a dependence. And it does contain magnesium. And so with elderly people, they oftentimes have less renal function, higher risk of renal failure, and with renal failure that magnesium does build up. Daily suppositories are a last resort, but again, we don't want people to be impacted and obstructed. Types of poop promoters include laxatives. So laxatives soften that stool. Cathartics soften and waterize the stool. Provide some cramping, so people need to know that they're going to have cramping with that. And then the purgatives are going to have a lot of cramping and watery stool. Types of laxatives can be osmotic, can be stimulant, can be bulk forming, and can be emollient. And that is the end of the GI meds.